So I welcome all of you to our today's molecular tumor board meeting. So we have 8 cases for today, and we have our chairpersons, Dr. Krishna Kumar Ratnam and Dr. Neelam Singh, who have joined. First presenter, please.
Yeah, so good evening, everyone. Are you able to hear me?
Yes.
Yeah, so I'm Dr. Lalita Shripati, clinical oncologist in Barbados. I have a case to discuss. Can we have the next slide, please? So there is actually a 65-year-old lady who was diagnosed with upfront metastatic colon cancer, and she was started on treatment by other oncologists, and she moved to a different country. So the patient got transferred under my care, and she came to me with this discharge summary where it was mentioned that she was diagnosed in October 2024, and she first received Xelox, and then she progressed and she was started on Zeliri. She progressed and then she was started on Lonsurf, and she came to me when she was on second cycle of Lonsurf. And when she presented to me, she came with complaints of dizziness and then increased cough with sputum. So I got the imaging done, and imaging showed a new single hemorrhagic metastatic brain lesion for which SRS was advised. And there was already a huge lung lesion, almost 10 centimeter in size, and then there was a liver lesion, sigmoid colon lesion. But after starting Lonsurf, the a small lung lesion disappeared, the sigmoid lesion and the liver lesion disappeared, but the previously 10 centimeter lung lesion now progressed to 14 centimeters, and then the brain lesion is the new development. So there is kind of mixed response. And when I got the NGS done, can you please share the next slide? Next slide, please. Next slide. So this was the result from the NGS. I asked patient about the number of cycles of Xelox. She couldn't exactly remember, but all she mentioned was when she was started on first line on repeated imaging showed progression. That's when she was started on second line. And she doesn't have any peripheral neuropathy. Her ECOG-PS is 2. Her hemoglobin is falling. It is currently around 9. And as per her, there is no bleeding. And she continues to have cough. And there is also ongoing weight loss. She is now 40 kgs. So there's been considerable weight loss. And this is the patient history. And this is the latest NGS report, which shows mutations in KRAS, GATA, APC, mTOR, and the other pathways. And then there is HRD positive, which is high, and then MET exon 14 skipping. But there is no microsatellite instability or tumor mutation burden is low, and also no other mutations. So I understand that it is a highly aggressive tumor, so I would want the opinion of the panel regarding her further treatment options. Also considering that she's having this ongoing weight loss and falling hemoglobin and PS2, and she's also battling concomitant fungal pulmonary infection, systemically stable but still on oral antifungals. Panel opinion, please.
First of all, I would like to get the opinion from the oncopathologist and molecular oncologist.
Okay. I don't know. I'm Arun Kumar here. Maybe I'll just have the conversation started on. It's a bit very complex report.
Yes, sir.
Also a bit surprising in a couple of fronts. Now, if you can just come down, there is also I think slide number 13. You have a table of all the variants with the variant allele fractions. Can you just come down now? Whoever is presenting? This slide. Yes. Awesome. So let me give a molecular perspective here. I also will invite my colleague Silambarasan to comment on it. What I see is that you have a KRAS mutation, which activates your MEK pathway. Then you have APC that activates Wnt signaling pathway, but it also activates your mTOR pathway. And you have mTOR mutation, you also you have two mTOR mutations, and there is a PIK3 mutation, although it's not PIK3CA, it's CG. So essentially, what one can see is that the MEK pathway and the mTOR pathway is rapidly activated in this tumor. But surprisingly, the report also showed there is a MET exon 14 skipping mutation. But I think they have identified that by RNA sequencing and not by DNA sequencing. Generally, MET exon 14 skipping, you also have a point mutation in the MET gene. Maybe they don't have probes to cover that intronic region of the MET. So I'm not able to comment whether the MET exon 14 skipping, what is the variant allele fraction, or is that more dominant clone compared to the VAFs that you see here. So in my mind, I think targeting mTOR in this case would be quite important, pathway based. So mTOR, and if possible, MEK also. The whether the MET can be targeted is something that we need to see. I still don't know. And one thing that seems off for me in this report is it says HRD positive, but I don't see any mutations that causes HRD positivity. None of the DNA repair mutations are seen to be here in a major form. So that seems a bit odd to me in this report. So this is my key takeaway, but I would also invite others to comment.
Yeah, thanks, Dr. Arun. So, as Dr. Arun commented mostly, right? This is Dr. Silambarasan here. So, I'm another clinical genomist, like Dr. Arun. So, as Dr. Arun mentioned, what I find out weird, as well as what is very well matching with the biological thing, is KRAS mutation is matching, as well as APC mutation is also matching, and the mTOR. So, these are looks fine. But what it is not looks fine in this report is MET exon 14 skipping, chances of coming in the colorectal cancer less than 1%. So, is there anything wrong in that one that we need to figure it out? As Dr. Arun mentioned, the second one is HRD. Colorectal cancer with HRD is very, very rare when there is no DNA repair pathway mutations are there. The surprising thing for me is even T53 mutation is missing. At least T53 mutation is missing somewhere 1 or 2% we can able to defend on that part, but here that is also missing. So maybe we need to question whether we need to do another repeat biopsy for the genomic testing. That's my humble suggestion, but biologically little bit of doubtful on that front. That's only comment right now I can give on that part. Otherwise, we can think about off-label means KRAS mutation is there, so MEK pathway is also there, and the mTOR pathway, so everolimus may add some value to it, but not that much effective. So the PFS and OS is going to be only 2.5, 3 months to maximum of 4 months. So that's what the data of everolimus is colorectal cancer is suggesting. So these are the two comments from me. So kindly consider another one more fresh biopsy of this patient if it is possible for NGS, or otherwise everolimus is one option for the mTOR pathway inhibition. So these are the two comments from my side.
Any other suggestions, advice?
This is Dr. Narendran, madam. So this patient now, except for the lung lesion and the brain lesion, other lesions responded, right?
Yes, yes,
And this
yes, sir.
endobronchial lesion, you have mentioned this biopsy and NGS in the endobronchial lesion. How big is the endobronchial lesion? Whether the patient has a complete collapse of any particular lobe, or it's just a small
No, sir,
lesion?
it's actually now it is like encompassing the entire lung. Now the earlier, previously the lesion was 10 centimeters in the lung. Now the lesion is like 14 centimeters. Almost entire lung is gone.
Starting from the endobronchial, I just want to understand whether it's the endobronchial, it started and it is causing compression of the complete collapse of the, because of the endobronchial lesion, there is complete collapse of the particular lobe, or whether it's in the parenchymal lesion.
It's a parenchymal lesion
Okay.
as well. Yeah, she was referred to pulmonologist to do the biopsy, and then pulmonologist did it through the bronchoscopy. But as such, her entire lung is filled with the mass, and there is also concomitant infectious inflammatory changes.
There's no bleeding hemoptysis.
No, sir, nothing as of now.
So
But
as a
she started having brown colored sputum now, just
okay,
quite
so
very recently in this week itself. Yeah.
So the lesion is occupying the entire lung now, not a particular lobe, almost the
Yes,
entire
yes,
lung.
yes. The left lung is entirely occupied by the mass, and in the right lung there was 2 centimeter lesion, which disappeared after starting Lonsurf. Is the sigmoid lesion and the liver lesion, but there is progression of lung lesion and also the brain lesion is a new development.
The brain, she is on RT now.
No, she's supposed to start SRS, single fraction.
Okay, so if there is a mixed response, but there is no bleeding, one option is you can continue the trifluridine tipiracil with you can add on bevacizumab if it's not given before. But
My
if there
only concern is the brain lesion is a hemorrhagic lesion. So is my main concern. It's purely hemorrhagic lesion, the brain lesion.
that the
And
risk is there, if it's bleeding
yeah,
and hemostasis also is there, then bevacizumab you cannot give. Then
yes,
ideally, if off label, if you don't think, the next option is regorafenib. But considering the so many mutations, I don't know whether regorafenib will help. So one option is switching to regorafenib, or if the patient understands, what I will suggest is, it's my pure decision. Based on multiple mutation is there, at least you can target the final pathway. So mTOR inhibitor with the MEK inhibitor. Uh, it could be this is purely a off-label option considering the NGS report. If when two inhibitors you start at the lower dose and then increase the dose. So this will be based on NGS, this will be the option. Everolimus with the trametinib. You
okay,
target the final end pathway.
okay.
If
Thank you.
bevacizumab can be given, then trifluridine with tipiracil with bevacizumab you can add on. If it's not, it cannot be given. Maybe you can switch over to regorafenib now. If there is no response, which again the disease is progressing, then off-label option you can after shared decision you can try mTOR inhibitor with trametinib, MEK inhibitor.
Yeah, thank you, sir. And we also have availability of the medications issue, considering the small country, Caribbean country, and everything needs to be coming from overseas. Is there any role of crizotinib for her just because of availability and considering her mutation?
Crizotinib is usually used for ALK and ROS, but
Yeah,
not for this pathway. So
like yeah,
this may
considering
not.
the mid-14 skipping.
So I think if the best would be at least to target the MEK, because even if you consider met exon 14 skipping to be positive, true positive, you also have the dominant KRAS here. So
Yes, sir.
if you have to choose between just two drugs, I don't know what the availability, MEK inhibition would be quite prudent and followed by mTOR inhibition, a simple
Okay,
everolimus or something.
okay. So thank you for all the suggestions. Thank you so much.
And this patient, since the patient progressed on Capox, while on Capox, not had a good response to Capox, I don't think so. This HRD positivity should be given important because platinum doesn't look like much sensitive to platinum.
Yes,
So
sir.
if there's a platinum free period was there, then another option again re-challenge Capox. But here already progressed on Capox may not be helpful much.
Yes, yes, sir.
That's a
I
very
agree.
good point.
Yeah,
That's a great
yeah.
point, Dr. Narendra. Yeah.
Thank you.
We move on to the second case, or Neelam, you have any points?
I think so. Yeah, I agree with the panel. So,
Okay.
so we can go to the next case.
Yeah. Second presenter, please.
Yes, sir.
Good morning, all. Shall we start?
Yes, please start.
Yeah. Next slide. Okay. So here is a 65 years old male. He's a case of metastatic CA right lung with diffuse skeletal mets, which is diagnosed in outside adenocarcinoma of lung. Then after that, we have given 6 cycles of platinum and pemetrexed-based chemotherapy. Then afterwards, in response assessment PET-CT, we have upfront molecular status has been not done because the tissue was inadequate for NGS report. And at the time, patient is also not willing to go with any repeat biopsy further. So that's why we went ahead with only chemotherapy with PEM and platinum, PEM and pemetrexed and carboplatin. Then after that, in a follow-up scan, patient had a partial response with reduction in size, and the lytic bone lesions has turned into sclerotic lesions. But at this point of time, patient was willing for liquid biopsy, and we proceeded with liquid biopsy, and still he's not willing for solid biopsy. But the liquid biopsy is showing EGFR compound mutation, exon 19 deletion mutation, along with T790 mutation is there. So our question is, since I'm working in a government institute, we don't have any a possibility of giving osimertinib plus chemotherapy. So is there any role of first generation like gefitinib or erlotinib or second generation afatinib in this setting of EGFR compound mutation, especially with deletion 19 and T790 mutation? Because the thing is, usually we know that the T790 mutation, as a germline mutation, it can occur in 1 or 2% only. And we don't, upfront itself, we didn't give any first generation or second generation TKIs. We have given just pemetrexed and carboplatin. So is there any role of giving EGFR first generation, second generation TKI in this setting?
So this patient progressed now on pemetrexed and carboplatin, right?
He didn't progress, sir. He had a partial response.
So initially liquid biopsy done, or only now we are doing liquid biopsy?
Only now we are doing liquid biopsy. Initially, the tumor tissue biopsy was done, which showed adenocarcinoma of lung. At the time, NGS was not done because the tissue was inadequate to proceed with further NGS report.
Okay. And this is not germline, this is liquid biopsy for correction.
Yes, liquid biopsy. But the VAF of T790 mutation is more than 50%, and deletion 19 mutation is around 14%.
So that will leave to the
considering the
molecular
VAF,
experts. All VAF is not equal to germline, that the molecular experts will further comment on that.
Okay.
Okay, so
Arun sir, over to you, sir.
So, see, the doubt, I think, rather the pointed question is whether this T790M can be germline and whether we can target it with second generation EGFR inhibitors. Although it is 53%, highly unlikely to be germline. It also, we have to look at it in the terms of what was the tumor fraction or the tumor content. This is a solid tumor, so it's a solid, right?
Yes, sir, the solid tumor.
It's a solid tumor. So
can we go to that NGS slide?
Yeah,
next
can
slide.
you just come down? Yes. So
solid
in this
tumor, but biopsy is liquid biopsy.
Oh, this is a liquid biopsy.
Yes,
Okay,
biopsy
okay.
is liquid biopsy. Yes.
Okay. So see, I still don't feel that this could be a germline. Very unlikely. Although if it is so, it is one of the rarest cases. But I think whether it's germline or not, given that it is a lung cancer, targeting that with osimertinib, especially given the co-mutation with exon 19 deletion, because the exon 19 is 14% smaller clone, and T790M is 53.5%. So I think it's most prudent to target it with osimertinib. Not sure if second generation TKI's role in this compound mutations.
Next
Generally,
slide.
you use that if it is some other mutation and not the T790M.
Next slide.
Yeah, that's what. Usually T790 mutation will occur
yeah.
after as a resistant mutations to first generation, second
Yes.
generation. But in this case,
Yes.
we are given only chemotherapy. So that's why
Yeah.
we got the doubt and how to proceed further. And we are also working in government setup. So that's why osimertinib is really very hard to get. So,
Okay.
so, so our plan would be
But
Actually,
academic.
T79, even 1 to 2% of the patients, even upfront, it can be there. It
Yeah.
is always not a resistant mutation. Frequently, it is a resistant mutation, but
yeah,
still,
yeah,
it can be
1
there.
to 2% germline mutation.
It can be there. So it doesn't mean that always it should be a resistant mutation. So here, considering the VAF of higher VAF, it should be targeted. So going with the first generation, second generation will not going to help with the T790I mutation.
And out of academic interest,
Yes.
if you want to test if it is truly germline, you can take a buccal swab or a skin scraping, and
Yeah.
if any lab is ready to do, they can do a Sanger sequencing for T790M. Just it is not going to change the way you're going to treat the patient, but that's
Yeah, yeah.
purely
To confirm
academic
it is
in
germline
nature.
or not. Yeah,
Yeah, yeah.
yeah, yes, I get it.
So, sorry, just for my understanding, is this patient is exposed to anything of afatinib?
No, sir. No, sir. Only 6 cycles of pemetrexate plus carboplatin has been given. TK, no other TK, I mean, TK is not given, sir. EGFR TK has been not given. TK naive.
Okay. Because this is going to be little bit of experimental only. Since T790M mutation is there, the second generation response will be little bit lesser. But having said that, it's the mutation EGFR exon 19 start with 747. Okay, so when the mutation usually 746 they will start. When it is start with 747, there is a small difference in sensitivity of the drugs. Okay, so
Yes,
one option definitely osimertinib is the best drug. There is no doubt about it. Flora, along
yes,
with Flora 2 is also even more better actually because the T790M mutation is there. But when the patient is not affordable, you can even consider of trying 20 mg, which is the low dose of afatinib also.
Okay,
Think
20
about
mg
it.
afatinib. Okay.
That is one more option is there. There are some data is available for the same thing. But
Okay.
chemotherapy will also be helpful. Whether that's what the experimental treatment kind of consider you want to do is afatinib and continue with chemotherapy or not. That is the choice is
Yes, sir.
yours.
Okay, sir.
Why
So
I
we
am
can
saying
consider.
is that earlier the FLARA 2 trial have suggested when you are combining with the TKI with chemotherapy, the response is much better. Especially the T790M mutation or P53 mutation, any mutation is present, that response is better. So from
Okay.
that angle, I'm suggesting. So if you cannot want to do that, only methodologically you want to go it, afatinib 20 mg you can start, and based
Yes,
on the
along
patient
with the
tolerability,
matrix.
you can go up to 40 mg.
Yes, sir.
Yes.
Yes.
Okay. Thank you.
Thank you, sir. Thank you.
Actually, here, if it is only the exon 19 deletion, then afatinib will help even in
Yes.
this mutation. But if it actually there is T790 also is there.
Yes, sir.
If you're not able to give osimertinib, the other option is a TMH data where you give chemo with geftinib. Chemo maybe will take care of some that 790 mute cells, and geftinib or afatinib will take care of the deletion exon 19. So that is an option only if osimertinib cannot be afforded.
Yes, yeah.
Otherwise, with the T790M, you cannot skip osimertinib.
Yes, yeah. Yes.
Thank
Thank you, sir. Thank you.
So what is the final plan, Dr. Narendran?
Also to point out the deletion which is here, as Silambar has also pointed out, it's not a typical deletion which we see 746 to 7450 deletion. Here it's a different site.
Yes, sir.
Some reports are there where it has a lower PFS compared to the typical exon 19 deletion. So overall, it's like a atypical deletion in the EGFR 19, and also T790 mutation is there. Ideal choice here will be chemotherapy with osimertinib. If patient cannot afford, then you can consider continuing pemetrexate with first, second generation
Afatinib or
of geftinib.
Yes, sir.
Only if affordability is a concern.
Yeah, that's it.
Okay. Thank you.
That's it. Thank you. Thank you so much.
Thank you.
So we will go for the third presenter, Dr. Zarin. Please go ahead.
Good evening, all. So, this is the case of a 52-year-old male. He's never smoked. He's a never smoker. He came to the ED with severe breathlessness. We saw a very symptomatic left pleural effusion. He was initially admitted under pulmonology. We took the cytology. It was malignant cytology was positive, and a PET scan showed disease nowhere else. There was pleural-based nodules and there was pleural effusion. He was stage 4 NSLC, and the on the histopathology, it was clear cut. It was an adenocarcinoma with TTF1 positivity. Unfortunately, the tumor cellularity was very low. It was nearly 5%, and then there were multiple bits of tissues. Based on that, we sent him for NGS, and because he was symptomatic, we started him off on chemotherapy, pemetrexed and carboplatin. Unfortunately, after chemotherapy, the NGS report came back, and the test could not be performed. And then we sent a liquid biopsy on him after chemotherapy, and the liquid biopsy report is as follows. There was no targetable mutation. So we were expecting to have some sort of a targetable mutation on him because he was a never smoker. He was a young man. So how can we know that this tumor report is adequate? This liquid biopsy report is adequate. If you could show the liquid biopsy report. So should we try harder to look for a targetable mutation? Is there any way to know that this liquid biopsy is indeed adequate, because this was taken after receiving a chemotherapy? Can we know the tumor content in this liquid biopsy? Is there any other method we can do? Now he received 2 cycles of pemetrexed and carboplatin.
This report is sent after 2 cycles of chemotherapy, right?
No, sir. After first cycles of chemotherapy, after the
Okay.
first cycle.
Okay. Sites of disease, can you tell?
Oh, sir, it was a very localized disease. It was localized to his left pleura. There was a pleural-based nodule, pleural effusion. MRI brain is normal.
So there's no other lesions elsewhere.
No.
Pleural-based lesion with the pleural effusion alone.
Yeah. The pleural fluid cytology was positive. So we had made a cell block out of the pleural fluid. We got the pleural fluid, pleural-based lesion also. So in everything, the tumor cellularity in each tissue was 5% only. So we gathered everything together and sent it to the NGS lab.
He's on ICD now, or
he was, but yeah,
now,
we removed it. We gave him a pleurodesis. Pleurodesis is also done.
Okay, so okay. So with the clinical history, would request molecular experts their comments, please.
So, Dr. Zarin, when
Yes, sir.
it comes to your point of whether this tumor content is sufficient, always you can write an email to the lab, the TAR lab, and ask for tumor fraction in this block sample, tumor fraction in the liquid biopsy.
Yeah.
Right. So I'm very sure if it is adequate, then only they will go forward for the testing. But to be on the safer side, I would request you to check whether the tumor fraction is more than 4-5% or not. So minimum tumor fraction need to be 4 to 5% to find out. Usually we will use this cutoff in the tumor fraction for the chip, whether to consider that chip or not. But having said that, more than 4%, 5% tumor fraction is the good adequate cutoff for to trust any report. Number one, you can find out. Number two, this is not the ideal time for liquid biopsy for 2 reasons. One is it's only one single nodule is present and the tumor volume size is very small, little, and the tumor shedding capacity is very, very low, to be very honest, right? That's number one. Number two, whatever it is available, already we have done even the chemotherapy also first cycle. So that will even further reduce the ctDNA if there is going to be anything is present. So because of that one, the level of ctDNA will be further down. So The next opportunity for us is once the patient is progressing, then only there is a chances that we will get something out of it. Even if we hardly try, that's what you asked, whether we need to hardly try for something else to find out, which means bigger panel. You are referring to 52 or 161 is not going to be helpful at this moment. So we need to wait for that. And also, I have seen downstream one more report of PD-L1 positive. Liquid
Yeah.
biopsy, PD-L1 positive. Bit careful. The sensitivity is only 60 to 70%. So no need to jump immediately for immunotherapy treatment based on that one. If you don't have any other option, if the patient is progressing, then you can consider on that part of it. So from this one, I would say that more than the biology, the testing of the lab, sorry, not the biology, the technical side of it, I'm seeing the biology itself is not favoring the liquid biopsy at this moment. So that's what I was saying. But write an email to the lab. There is no point in asking them what is the tumor fraction, what they have extracted in that sample, so that we will have the double confirmation that we are in the right track.
Yeah. Yeah.
Right. Please, others, you can comment on this.
Yeah, maybe take home message, I would say, which for any liquid biopsy, don't give a liquid biopsy immediately after a chemotherapeutic cycle. Chemotherapy drastically drops down the uh, available DNA, tumor DNA in the blood. So that's very evident from here. I can maybe in the group also I can share a couple of publications. Enough publications are there where how the tumor fraction is impacted with various parameters, clinical and biological parameters, including chemotherapeutic exposure. So I think that's what is playing out here. Uh, Even if you ask the lab for the tumor fraction, most of the tumor fraction algorithms work based on detected mutations. So if you identify a mutation based on the variant allele fraction is how they identify the tumor fraction across various SNPs across the genome. So you may not get a report also, even if you ask the tumor fraction, not this lab, any lab. So you may want to try, but definitely this patient's tumor fraction in this time was low. Uh, Also, if it is highly metastatic disease, so and the disease burden is also high, and you don't have an option but to sample the patient or do a liquid biopsy, draw the blood from the patient for a liquid biopsy, the best time would be 1 day before the next cycle of chemotherapy, provided you're giving a 3 weekly therapy. If it's a metronomic weekly therapy, it adds on further issues. But if it's a 3 weekly kind of a therapy, then 1 day before the next the scheduled therapy, you can take the blood and see. But that too, we don't know how much it will work. It can work provided the disease is large. So
So
that's my take.
what is the possibility? We know NGS is not possible. Whether in this case EGFR by PCR can be tried, which comes positive, which comes negative, then again we cannot take it as a negative. We have to again wait for progression.
Correct, sir.
EGFR by PCR and AL cross by IHC, whether that can be tried here.
If tissue is there, I think there should be no problem at all. This the whole problem is because of liquid biopsy. Even if there was pleural effusion, one can make cell block and from the pleural effusion fluid and take it up.
Now it's again a fluid is done. There's no effusion.
Yeah,
that's why Dr. Narendran sir, actually to do the PCR, we need some genetic material, right? So here everything is zero. So that means the genetic material is very less. Number one.
No. From the
Number
tissue
two,
block I'm asking. From the
the
beyond the
tissue
block,
block you can do, sir. Yeah,
because
if the
that is
tissue block is
inadequate
available,
for
we can try.
NGS. Inadequate for NGS.
May I add, Dr. Narendran, Dr. Rajesh here.
Ah,
We
sir.
have had similar situations. Droplet digital PCR is a good modality for that 5% tumor content in the paraffin block as an alternative for EGFR testing. And if we still have even a few tumor cells, ROS or ALK first, followed by ROS, either by IHC or by FISH would be an alternative. Actually, ALK, we want to see diffuse expression. If the cellularity is very less, it's a problem, but still, uh, at least EGFR on the 5% tumor block by droplet digital PCR would be a beginning, would be a very important beginning. We have had many such situations and it is helpful. Thank you.
Oh, thank you, sir.
So could you interpret that PDL1 report also? I've attached the second report as well. What is being said? If we scroll down, perhaps.
But is this doing PDL1 from a liquid biopsy is validated one?
Yeah, how do I interpret this report?
Because
Like that
Yeah.
TPS percentage would not come out of a liquid biopsy, but what is this positivity? So does this mean there was enough tumor content in the
This is
liquid
not a
biopsy?
valid.
Yeah, this is
I
not
would be not be. I would not
see
be
they
able to.
in all probability. I mean, what would have been done is the CTC would have been taken, a circulatory tumor cell, and captured. Maybe one or two of them would have been captured. In that, this PDL1 has been done, but I would take it with a pinch of salt. I would not jump into therapeutic decisions based on this.
Correct. So that's what I also recommend. So don't come into the therapeutic decision based on this one. So it's only 60%, 70% it will be true. So if you have no other option, then only you need to think about. So keep this one in the last self. Don't act on it immediately. So as Dr. Arun also mentioned, it will be extracted from the blood sample CTC, and then they will be testing it out. So there is no quantitative, and also there is no much of validating data on that part of it. Okay.
Now, does it indirectly mean that there was enough tumor content in the blood? Because there was.
No, that also we cannot say immediately on that part of it. So all the CTC need not to be counted is there enough tumor content is there or not. It's like Dr. Zarin, it is like you are taking the acetic fluid. So from the fluid we will be seeing cancer cells, positive cells, right? So similar
Yeah.
to that, from the blood sample, the circulating tumor cells are positive is there. That doesn't mean that the ctDNA will be sufficient for the testing purpose. So obviously, if the ctDNA is not sufficient, they will not perform the testing, but it is not good enough to find out the mutation because the tumor size is very, very little from that front. So that's a problem right now. So we need to go with the standard of treatment, or otherwise, one of the doctor have suggested, Rajesh sir have suggested, my memory serves, you can try out the droplet PCR for the very, very tiny sample because the VAF percentage, even though 0.001, the droplet PCR can able to pick it up. So that is the one way to go forward for the at least the EGFR testing, provided we have tiny of DNA samples is left over. Because already you mentioned only 5% of the tumor content is present. By now, I'm afraid that that would be all of them are exhausted already. So otherwise, you can request for the DNA which was extracted from the lab, whether they can spare for the droplet PCR or not. That also you can check it out. So that material can be utilized for the test. So these are the two options you will have. Whether they can able to spare the DNA if they are not discarded, they are lucky enough, then it will be there. So I think it is only this month only it has been done. So definitely they may not discard it. So you can request for the DNA which was extracted from the lab. If they are kind enough, they may be providing that.
Yes, sir. I'll do that.
this particular patient, as everyone suggested, either digital droplet PCR, at least from if the 5% content of tumor tissue is there, tumor in the tissue, then can consider that. And then IHC if possible, or you wait for the progression. As of now, continue chemo. At progression, you can do a tissue biopsy and then send for NGS. If possible, at the time, liquid biopsy also you can repeat.
Okay, then we'll go for the next presenter. Dr. Ramakrishnan, please.
Sir, case 4, can I discuss? I'm Dr. Kiran from AIMS Bhubaneswar, sir.
Yeah, sure. Go ahead.
Yes, sir. I'll give a short history because this case was entirely worked up outside. Good evening, everyone. He's a 59-year-old gentleman evaluated for persistent pain in the upper abdomen for the past 6 months, with history of loss of appetite, loss of weight, almost 10 to 15 kgs in the past 4 or 5 months, associated with low backache. He's a diabetic, tobacco chewer for more than 30 years, with history of alcohol intake since 10 years, 7 to 8 drinks a week, but a non-smoker. On examination, he was ECOG 1, BSA of 1.7. There was a left large supraclavicular lymph node palpable, 2.5 to 3 centimeter hard in consistency, and per abdomen just hepatomically was there. Rest of the examination was normal. Imaging, which was done outside, initially CECT, showed a well-defined heterogeneous lesion of around 7 to 8 centimeter uh, in the abdomen. It's like it's near to liver, involving segments 5, 7, 8. There is no venous washout. Multiple enlarged lesser omental and retroperitoneal lymph nodes, and one enlarged big 2.8 centimeter left supraclavicular lymph nodes. Prostate, bladder, everything was normal. Endoscopy was done, colonoscopy was done, everything was normal. Even tumor marker CA, CA19, AFP, PSA, everything was within the normal range. So biopsy from the left supraclavicular lymph node was done. It was suggestive of metastatic poorly differentiated carcinoma. Kindly show the slide of, go to the slide of 69 number, please. 69. Yes, thank you. Here we can see it showed metastatic poorly differentiated carcinoma, IHC strongly positive for MUC1, patchy nuclear positive for NKX 3.1, and occasional cells were positive for PAX8, but negative for CK7, CK20, Glypican, CD10, P40, and HEPAR. So most compatible with prostatic primary adenocarcinoma. Kindly correlate with imaging and PSA levels. But PSA was normal, imaging was also normal. So diagnosed as CUP and he was started on gemcitabine and carboplatin day 1, day 8. With that 2 cycles, he felt symptomatically better. At that time, he self-referred to us. We re-evaluated with PET scan, whole body PET scan, both FAPI and recently PSMA PET scan was done, where prostate is normal, only mild prostatomegaly is there, but there is no uptake. Only there is FAPI uptake or PSMA uptake is seen in liver and RPLN and SCLN. And the NGS, kindly go back to the NGS slide. Slide number 63. Yes, this showed third positive, CRBPP positive, TP53 mutated. There is tumor mutation burden is low, MSI is stable, genomic instability metric is also low. So our question is like in this summarizing 59-year-old gentleman were diagnosed and being treated as carcinoma unknown primary with biopsy suggestive of prostatic primary, but imaging and prostate PSA is within normal, but clinically responding to systemic therapy containing platinum. Our question is how to interpret the IHC and NGS and any further IHC required to identify the primary, guidance for site directed and effective management.
Can you show the image findings also, please?
Image finding it is there, sir. Kindly go scroll down.
Can you go to the report? Somewhere I saw the pancreatic mass, like.
Report is there, sir. It
Yeah.
is like FAPI expressing soft tissue mass involving proximal body of pancreas.
Can you go to the report?
Just
Can
scroll up, please.
scroll down. Yeah. So there is a pancreatic head mass also here.
Yes, sir.
Apart from that, there is a liver lesion is there, and retroperitoneal nodes and the supraclavicular node.
Yes, sir.
Okay. Now, can you go to the IHC report and further want pathology experts to comment on and how to proceed further?
IHC is on 69.
Yeah, the IHC report, what he showed, will fit in with the pancreatic tumor. It will all be overlapping. So, in correlation with this PET CT, it will be more of a pancreatic tumor than.
It's because of the MUC1 positivity, sir, pancreasis.
Yeah, MUC1 positivity is very well described in pancreatic. And so this, unless it is interpreted in this thing, consultation, if you see only the IHC, then it is very difficult. And that NKX2 is just very few patchy positivity.
Sir,
So,
but the CK markers are negative. That's why we were confused. Like,
Good evening,
yeah,
Dr.
this is
Chandrasekhar
poorly
here.
differentiated.
Yeah, I would like to agree, of course, with Rajesh sir. And CK7, yes, see, pancreatic primaries, CK7 can be positive or negative. Generally, it is CK7 positive, but not a must, IHC, as we have been time and again discussing, it is not a foolproof marker if it is taken alone. So, as Rajesh sir was rightly pointing out, I think it has to be taken in conjunction with the clinical consultation as well as with the imaging findings. MKX 3.1 without PSA, again questionable. Poorly differentiated prostatic carcinomas can show MKX 3.1 alone, but still a focal positivity is again questionable. Diffuse strong pattern of staining also is important in IHC. So a diffuse strong positivity will favor one primary over the other, but definitely not taken alone. It's not going to help us if taken alone as an IHC as a single diagnostic modality. It has to be taken in conjunction with imaging findings and clinical presentation. So pancreatic primary should be considered here, even though CK is negative, because there are instances wherein pancreatic adenocarcinoma has shown a CK720 negativity as well, both CK7 and CK20 negativity. Thank you.
You want to rule out any possibility of neuroendocrine carcinoma here, or just it's a ductal carcinoma?
It is possible, but I'm not sure if the workup is for the neuroendocrine is done. Neuroendocrine
Yeah.
is possible.
Yes, sir. I mean, even we were thinking the same of a neuroendocrine possibility. So we have just sent all the neuroendocrine IHC markers as well. And we were of the opinion because the CK7 and CK20 was negative. So we were kind of excluding it as a GI primary. We were thinking like, since the NKX 3.1 is positive and that's highly specific for prostate cancers, and patchy expression still can be seen in poorly differentiated or the aggressive variants. So we were
The
actually
word
planning to do some.
specificity is something which is a very dicey word. There is
Right,
nothing
sir.
100% specific. More the
Right, sir.
experience, the
And
specificity.
also one more thing which I wanted to, yeah, one more thing which I wanted to add here is neuroendocrine you've sent for IHC mark
ma'am, we have
about the
rebiopsy.
morphology of the tumor, because neuroendocrine definitely will have a, yes, sir.
Okay.
Sorry.
Morphology. Okay, okay. We have done a repeat biopsy
Yeah.
and reworking on this block also, ma'am.
Yes, sir. So, meaning you can ask the consult the pathologist again, discuss with them as
Yeah.
to relook into the same slide and then into the
Yeah.
rebiopsy tissue also. Because neuroendocrine differentiation, if you just go by markers, I'm telling you again, synaptophysin will be positive in n number of tumors, not only in neuroendocrine. So, 2-3
Right.
markers can help out, but not without morphology, not without imaging and clinical findings, as we always discuss. So, that's something which I want to include. Thanks.
So ma'am, you would treat it like a pancreatic malignancy.
Yes, if there is a pancreatic mass, don't go by IHC alone. And moreover, pattern of IHC also is not in favor of a prostatic adenocarcinoma. It is because it is patchy and faint, is what is written there. I've not seen the slide. But with the description you people have put forward, patchy and focal staining without a mass in the imaging definitely should not favor a prostatic primary. And when there is especially a mass in the pancreas in conjunction with the imaging, if you have to take the whole case into account, I think you can consider a pancreatic primary. And neuroendocrine differentiation or not, please ask the pathologist to relook the morphology and then go ahead with ancillary techniques like immunohistochemistry and not just ancillary techniques like IHC alone. Thank you.
Any serum markers were done for?
Sir, CA, CA19, everything is normal, sir. AFP, everything within normal range.
Okay.
Tumor markers are normal. The PSA is also normal. Also, that I was thinking if we should go ahead and do a PSMA PET.
You can, but see, there is existing evidence for a pancreatic mass. I think that if you rule it out, then you need not be spending more and more on that. Now we need to confirm for
Right.
the evidence that is already available.
And
Right, sir.
how to interpret this NGS, or any value, like we can carry out any further testing or treatment based on this NGS report?
Can you please go back? I am not.
Sir, one thing which I noticed I wanted to put forward before Rajesh sir takes over and the NGS experts here are taking over. Third, like to my knowledge, and P53, I think both are positive in this particular case, which indicates that at the board, the patient will behave in a, like, it's not a good prognostic marker. So that is all I could infer. But the experts, the genetic and molecular experts here can probably add in their views too.
Because he's on broad spectrum, broad anti-systemic therapy, gemcitabine, carboplatin, which has platinum, which works in majority cancers, gemcitabine, which work probably in pancreatic or something, like other GI malignancies also. So he has felt symptomatically better with systemic therapy.
Oh, okay.
NGS, can you roll to NGS just 2, 3 slides above? One more
Yeah,
slide above.
you can go up.
Yeah, one more. Yes, this one.
Yeah, so I did have a look into this NGS report. Now, what is surprising is we see a TERT, a TP53, and a CRE-BBP mutation. Now, if you don't give me any clinical history and ask me to look at these three mutations and guess what could be the tumor, I would say it is some kind of a myeloid malignancy, because CRBPP is a very common thing that you see in lymphomas and many myeloid malignancies also. So I am not sure how to interpret this, though we don't see that many CRE-BBP mutations. Along with TERT. TERT is also very common, although in both solid tumors as well as in hematological malignancies. But these three combinations is very, very common in the other tumors. I'm sorry, in the liquid malignancy. So
AML, acute myeloid.
AML, yeah. So I'm not. I don't. We can't interpret this and make any clinical sense, at least for this particular case, CUP case. So, but I presume this is not a liquid biopsy, right? This is a
It's a tissue biopsy, tumor
tissue
on
biopsy.
sir.
Okay, okay. So, whether this aspect, what I said, can help you with finding tissue of origin, I don't know. But you don't have any therapeutic relevance, even if it is truly positive in a solid tumor tissue.
Thank you.
My suggestion is if you can finalize the origin and the type of tumor, you can titrate your chemotherapy accordingly to
Yes, sir.
minimize the toxicity. Thank you.
Yes, sir.
Sir,
This,
one more question.
go
Sir,
ahead,
one
ma'am.
more question. So, is it mandatory, sir, for you all to find out the tissue? Yes, of course, the ideal thing would be to find out the tissue of origin, but in case you're unable to, like in this particular case, of course, pancreatic primary is one good possibility over here.
Based on imaging, looks like pancreatic primary only, ma'am. But what could be either it could be a neuroendocrine carcinoma or whether ductal carcinoma, or based on this NGS, whether it still can be a lymphoma possible here. That is the question. Because lymphoma also gemcitabine can work.
Yeah, but then IHCs will rule out the lymphoma, isn't it?
So
So,
for
we
further
again
IHC,
go back.
could we do for lymphoma also here?
I
This
do
will
not.
help only on discussion with the pathologist. Yeah, you have to find out the morphology, discuss with them if they are considering a lymphoma as well, and then go for IHC, because like otherwise it will all be confounding. You have to take them into confidence and have a discussion. Like if it's a poorly differentiated round cell tumor, then yes, of course they will also be considering the possibility for lymphoma, and then add the IHC marker. I think you will get some answer whether it is a lymphoma or not.
So we can
Thank
take
you.
the
I would not.
confirmation as origin from pancreas, but for the type of the poorly differentiated malignancy, further IHC should be evaluated, right? Can we
Yeah.
go ahead like that?
Please.
Yes.
Actually,
Yes.
lymphoma, I would keep it very low because I saw the report, the way they have described it is from a good center by Dr. Ilan Tendal, who is a reasonably senior enough person. I do not expect the lymphoma. It will be a surprise. Anything can happen, but it's unlikely. It is most likely an epithelial malignancy. That's why they have favored a poorly differentiated prostatic primary. I think the image findings would not have been available at that point of time. Now it is highly favoring a pancreatic primary. That can be confirmed and worked out and proceed further.
Thank you,
So
sir.
another one more suggestion from my side is if the patient is affordable and we wish to desperately find out the cancer of origin, there is no harm in trying methylation sequencing from garden is one option. Or otherwise, if there is any other company which is doing RNA transcriptomics, that also will give him the option where the origin of tumor, provided if the patient is affordable. We want to establish strongly the cancer of origin means go ahead, or otherwise consider as the other experts suggested and start the treatment. So that's one option is there, but how desperate we wanted, how much patient is affordable, that will be coming into the big question mark on that part. If you want that part, academically interested, then you can very well explore the methylation sequencing. So that will give the clarity of the tumor of origin based on the genomic data. Methylation sequencing or RNA transcriptome is another option.
Thank you, sir. Thank you, sir.
So for this patient, the summary is that the imaging is suggestive of pancreatic lesion and IHC also suggestive of pancreatic primary. So you can go for a further IHC studies to look for type of malignancies. And since patient responded to gem cargo, which is one of regimen in pancreatic malignancies, mostly it be a pancreatic primary. And the type of malignancies can be further categorized by IHC and morphology. And if for academic purpose, if you want to do, you can go for the RNA transcriptomic study. So thank you. Next case.
Thank you.
Hello, sir. Shall I present, sir?
Yeah, present.
Sir, my case for today is a case of CA esophagus. Initially diagnosed at March 6th of 2025. He presented with on stage 3, a 63-year male. Initially, next slide, please. We gave CTRT according to cross protocol. The patient had a residual disease. So we went ahead with paclitaxel and carboplatin 4-cycle. Then the PET scan, we did a PET scan which showed a esophageal response. There was no residual lesion in the esophagus, but there was a lung lesion. So we gave SBRT to lung with 50 gray in 10 fractions. And then we actually planned for palliative chemotherapy. At this point of time, we did the NGS. Next slide, please. Next slide. Next slide. NGS done, which showed a dual TP53 mutation, one missense mutation and one nonsense mutations, and a pole D1 mutations. The question for today is whether a significance of dual TP53 mutation in this case and oncogenic relevance of pole D1 mutation and next line of management. For this case, we have planned for 4 cycles of palliative chemotherapy with irinotecan. So right now, whether dual TP53 mutation will change any treatment or pole D1 mutation any oncogenic relevance.
So what is the panel covering in this tumor focus panel means how many genes are covered and what are the genes covered? Can we go that? And any PDL1 test is done here.
PDL1 testing is not done, sir.
Okay. And how many genes covered? What panel it covered? Can we go back to when can we see that and then come to the report for the molecular opinion?
Okay. Next slide. It is in the last page of gene analysis. Next slide. Gene.
Okay.
Okay.
Okay. Can go back to the report and further molecular experts' opinion, please.
Yeah. So this seems to be a very targeted panel, definitely. And just two TP53 mutations are identified, and one Paul D1, not D1.
Yes, sir. D1, sir.
D1 now, VUS is identified. Now, that is truly a VUS. However, it is there
Okay.
in the active domain of Pol D, that is the DNA polymerase exonuclease 1 domain, it's there. But it has not been described, so we don't know the functional significance of it. If you
Okay, sir.
had done a larger panel, you could have got a tumor mutation burden estimated. Because if you know that if the Pol D1 is truly pathogenic, you expect either MSI to be high or at least definitely TMB to be high. Now, because that's like a functional checking of the pathogenicity of the particular mutation, because the gene is so, you can functionally evaluate based on the TMB. So, with that
Yes.
not being present, I am not sure. I don't think you can act upon it. If TMB is high, then of course you have choices of therapy.
Okay, sir. Sir, if TMB is high, what shall we consider, sir?
A TMB is high, then this Paul D1 is definitely driving it, because I didn't see
Okay.
any other variant that can cause TMB high, and any mutation in the polymerase gene, because that causes, that is the DNA polymerase. It's a complex protein, one of the subunits of that protein. So that will cause high TMB. You would have seen Pol E mutations in endometrial cancers or a few other
Yes, sir.
cancers causing super high TMBs. It will be in the range of 70s, 80s, and 90s. So,
Okay, sir.
of course, because this is a very short panel, I don't, that's the reason why you don't see many other mutations also. So, if you can do a comprehensive genomic panel with more than, 300, 400 genes, then only the TMB can be estimated. So, my takeaway would be to check that and see if this Paul D1 is truly pathogenic. That opens up an avenue of therapeutic options for the patient.
Okay, sir. And the significance of
Yes.
dual TP53, sir?
I mean, that's hard to
Both.
say. Yeah.
Okay, sir.
Please go ahead, Dr. Narendra.
Mm.
Okay, so and also one more thing, as Dr. Arun mentioned, so if you want to find out the pole day and be cost effective, I think MedGenome is having only TMB calculation itself. They will do and then give it to you. Since already the sample is
Yeah.
with them, so as per the TMB calculation only for this same case, if it is from the
Okay,
same
sir.
thing or otherwise, they can able to tell you the data on that part. So that straight away, as
Okay.
Dr. Arun mentioned, the tumor agnostic TMB high pembrolizumab option will be open up for the patient. And
Okay, sir.
otherwise, if you want to still go ahead for the bigger panel, also no harm in trying one more option, because we never know what kind of other mutations we will be picking up in the bigger panel. If it is matching with the biologically esophagus, then also the other options will open up. But most of the guideline based genes are already covered. So from that perspective, I would recommend only just to the TMB calculation from the genome immediately, or otherwise you can go ahead for the comprehensive genomic profile whenever the patient is affordable. The next.
Okay, sir.
So when both the missense and nonsense mutation is present in a different region, will it be like will it make it a prognostically different compared to a single TP3 mutation? That's what he was asking.
Yeah. Yeah, sir. Exactly.
See, I'm not sure in esophageal, but yes, definitely in NSCLC it does have some studies. But yeah, one is a nonsense, the other is a missense. Pathogenicity wise, nonsense is much more poorer prognosis, because you just have half the protein or less than half the protein being synthesized. So having multiple TP53 mutation is overall in all solid tumors poorer prognosis, no doubt about it.
Okay.
Okay, sir.
So this patient from so for clinician side, what we can do is actually this patient you can check for PDL1 and also by heteronew IHC. So if since you have given only chemotherapy before, if PDL1 is positive more than 5 or more than 10, another option is immunotherapy. So anyway, going
Okay,
for
sir.
irinotecan. So you can either add on immunotherapy. If response is good, you can continue immunotherapy. And head to new also,
Okay,
some cases the head to new also can be positive, so you can check by head to new IHC also here.
okay, sir.
Okay, thank you.
Okay, sir. Thank you.
Next presentation. Yeah, by Dr. Narendra.
Okay, next slide. This patient diagnosed of metastatic castration-sensitive prostate cancer in March 2023. Archidectomy was done initially, followed by docetaxel since the patient had a high risk and high volume disease. Docetaxel with abiraterone was the PSA was more than 100, and after treatment the PSA. So he was continued on abiraterone maintenance for about 2.5 2.5 years. Now the PSA is normal, but patient had a hematuria and lower urinary tract symptom. So further evaluation, since the PSA was normal, we did both the PSMA PET and FDG PET. PSMA PET, there's no uptake was there, and FDG PET showed uptake in the prostate and in the iliac node. So iliac node biopsy was done, which is both morphologically and IHC suggestive of neuroendocrine carcinoma transition. So he was started on carboplatin, etoposide, and immunotherapy. So first cycle only chemo was given. From second and third cycle immunotherapy was added. But on treatment, he had again hematuria, pain, and again a PET now done now suggestion of progressive disease. So RT to the prostate and iliac node was given. The progression was from the local again, not in the distant site. So the curative dose of RT to the prostate and iliac node was given. Next slide. Now patient has completed RT. Meanwhile, we have sent NGS. Can you go to that NGS report? We have sent for NGS, comprehensive NGS along with the TMB and MSI. But considering the tissue inadequate, they couldn't do the TMB and MSI. They could do only the other NGS panel. So the final report was this TP53 mutation and AKT mutation and other DICER1 and CTNNB1. So here, considering usually if it is castration resistant prostate cancer as an off-label final option, we can consider the CAPI-AKT inhibitors. But here, neuroendocrine carcinoma, I don't know how much it will help here. So my concern is to go for the next line with the chemotherapy, that is irinotecan with or without carboplatin. And immunotherapy have already failed, considering the probably a cold environment with the DICER1 due to DICER1 other mutations. So wanted to have an expert's opinion here.
Yeah, maybe I'll just give my thoughts on the gene mutations and the choice of therapies. Now, AKT1 activates a mTOR pathway, PIK3 mTOR pathway, and CTNNB1, as I think the first case also, the colon case we saw, beta-catenin pathway also activates the mTOR pathway in addition to it as a side one. Now, TP53 is the dominant clone. Now, this is just my thought. PD1 inhibitors versus PDL1 inhibitors in neuroendocrine tumors is a thought I just have. Maybe you can also opine, because if I take the equivalence in small cell lung cancer, the efficacy of PDL1 inhibitors, your durvalumab and atezolizumab, is more. And that's why the FDA approval also, or the NCCN guidelines, gives that as a first line option there. So given the immune checkpoint inhibitor you use is a PD1 inhibitor, taking parlance of neuroendocrine differentiation here, I think it may not work. And secondly, this doesn't show, okay, CTN and B1 could cause this to be a cold tumor microenvironment. You rightly mentioned, and that could also be a reason why immune progression has happened. But I would still not shy away from suggesting a mTOR inhibition in this case, because I see 2 out of 4 mutations activating the same pathway. And TP53 being the most high frequency, I think the currently you can also think of targeting the VEGF inhibition. So these are my takeaways, Dr. Naren.
So hi Naren, Krupa here. Hi Arun sir. So so one thing, Naren, I mean, like we pointed out, I think RB loss and P53 probably could have predicted for your neuroendocrine transformation as well. Number one, and we've already spoken about the cold tumor microenvironment. Getting back to the question of PD1 versus PDL1. To the contrary, again, I mean, like we know there are other ligands which can go and activate the receptors, not just about PDL1 as well. PDL2, the expression is also being looked at and correlating that with outcomes. So again, and that's probably another reason as to why, when we talk about the efficacy and the toxicity also, the toxicity profile is slightly different for PDL1 inhibitors, slightly less toxic and probably, if I might put it that way, slightly less toxic and probably slightly less efficacious as well as when compared to PD1 inhibitors. And if you look at all hematological malignancies as well, none of the PDL1 inhibitors. Interestingly, in extensive stage small cell lung cancer, there is a head-on-head trial looking at atezolizumab plus chemo versus serplulimab versus chemo. So that probably is very interesting because you have a head-on-head. Very rarely do you ever get to see a head-on-head trial, with one IO against that. Probably that will tell us the answers to which one or which PD1 or PDL1 is better, even in extensive stage small cell lung cancer. And again, if we are looking at identifying the molecular subtypes of small cell lung cancer, and we are extrapolating all of this data from small cell lung cancer or neuroendocrine carcinoma. And we know there are molecular subtypes, like for example, the neurod1. But I'll tell you again, the inflamed subtype is the one that actually responds the best to IO. Even when you look at small cell lung cancer as well. But having said that, Naren, coming back to your patient, and you've already given platinum with IO, and patient has progressed. I mean, like probably cabazitaxel is another option that I would probably even look at. And then again, temozolomide if you want to look at treating it like neuroendocrine second line. So I think I would probably look at doing chemotherapy here. And what was the progression-free interval, Naren? I missed that. I mean, how long did the patient go on chemo plus after
2.5 years, sir.
No,
Two
I'm
and a half years on abiraterone.
Okay.
So diagnosed in March 2023, archirectomy done, received a docetaxel, high risk, high volume disease. So received a docetaxel with abiraterone, followed by abiraterone maintenance for around 2.5 years.
Okay.
And then I had PSA is normal, PSMA PET normal, FDG PET picked up prostate along with iliac nodal disease.
Okay.
So 3 cycles itocarbo and toripalimab progressed with the iliac node size increase and new nodes are there, and patient was symptomatic. So a curative dose of RT given.
So was
Now,
this on progression?
On progression, sir.
No. I mean, were there any other new sites of disease or?
No. Only prostate and iliac node.
Okay. So the disease is still confined to both the prostate and the iliac nodes. No other sites of.
No sites of disease. RT is given. After RT is somewhat better now.
Okay.
Of Foley's catheter and no hematuria now. But we are not done the image. We are waiting for 12 weeks for since the date of RT. So meanwhile, we wanted to start on a second line of therapy. So my plan is to give irinotecan with probably off-label option with bevacizumab we can add, or just only irinotecan is my option.
But if you're probably treating this as oligoprogression, and if the patient has had symptomatic relief, probably then you can even wait until progression to start your second line therapy. I mean, because you're looking at starting irinotecan right away, right? I mean, whatever. I mean, be it.
No, considering biology of disease, we don't know whether how far it will come.
No, correct. I mean, we know. We know that the biology of the disease is pretty aggressive because ever since he's had a neuroendocrine transformation and he's progressed on platinum as well. So we know it's very aggressive. But the point is, what are we trying to achieve when the patient has already been palliated sufficiently, and that's the only site of disease? And you've given a curative dose of RT. That's what you said, right?
Yes, sir.
Yeah. So when you've already done that, I think you can even. Just wait. until progression to look at starting on second line chemotherapy. Had it been any other sort of oral medications or maintenance therapy, then probably yes. But if you're looking at second line chemotherapy, I would probably wait until somebody's symptomatic or has got radiological progression elsewhere before I actually start them on second line chemo.
We don't know how far the disease is under control, whether it's.
No, but I thought you just said that there are no other sites of disease on the current imaging.
No, after RT, we have not done imaging now.
Yeah, then probably you can look at getting a repeat imaging done as well. Look at the response, and then probably you can take a call after that, because if the patient has responded, I mean, like you're saying, good clinical response, patient is asymptomatic, now the pain is settled. I think that's why you gave radiation as well, right? And so I think as far as second line chemo, the other options are, like I said, cabazitaxel with carboplatin. You can look at re-challenging carboplatin as well. Probably if you have a platinum-free interval of at least 3 months, you could do that. So I think right now, if you've achieved palliation and there are no other maintenance therapy options, you can just wait and watch. I mean, like, see, treat them at obvious progression. I mean, like, I definitely not chemotherapy right away, because you've already given.
Why cabazitaxel, sir? This patient neuroendocrine transformation is there. Still, you want to go for like prostate, like second, or why not inotic and other regimens?
Again, I'll tell you, Naren, whatever we are trying to, whatever, the IO that you've given, or, platinum that we're looking at giving, all of this is extrapolated from small.
Yes. Yeah.
There is no particular phase 3 randomized level 1 evidence looking at only neuroendocrine carcinoma of the prostate. So again, and there is phase 2 data, again, look for cabazitaxel with carboplatin as well, weekly, called the CABAT-C study. So, again, I mean, like, so, all that I'm trying to say is that, that's another option as well, which you could definitely look at, contemplate doing, for your patients. You said docetaxel was given 2.5 years back, right?
Yes.
So it's pretty long time for, since your patient has been exposed to a taxane, and we know even in patients who progress on dosi, cabazitaxel helps overcome the resistance mechanism, the P glycoprotein efflux mechanism, right? So it does work, and there is a theoretic rationale behind it. The mechanism is there. So yeah, Cabasi plus Carbo, phase 2 Cabasi study, you already have data as well, albeit not particularly only for neuroendocrine carcinoma of the prostate. But I think we could look at doing that at progression, Arun.
Okay.
Hello, Arun sir. I have just small
And
thought.
for Arun said
Yeah, Arun sir, and Simbu wants to say something. Simbu, yes.
Yeah, sir, one small thought. Maybe Kuba sir, you can correct me if I am going wrong also. There is a Capitula trial, which is Capitula 281 is there. For the AKT mutated, this kind of P10 deficient or AKT pathway activated prostate cancer, metastatic prostate cancer, they have tried capivasertinib with abiraterone, right? So, and they have shown that radiologically PFS is also stronger when compared to the control arm. So, if we can draw a parallel line along with that one, capivasertinib patient cannot able to afford it. So, how about everolimus with abiraterone plus prednisolone?
See,
so that combination will be helpful.
Yeah. So I'll again talk about the Capitolo, since you brought it up. Unfortunately, the Capitolo was a negative trial. I mean, like, it was a negative trial. It did not meet its primary endpoint.
Correct, sir.
It was not statistically significant. So, unfortunately, and that's the reason as to why it's still not yet, made headlines or probably been approved yet. So, which is why, yeah, I mean, like, see, the rationale, as even Arun sir was trying to point out, that here we're talking about targeting the PI3K, KT, mTOR pathway makes sense, makes molecular sense, if I were to put it that way. But unfortunately, the data, and more so even in neuroendocrine carcinoma of the prostate, I mean, like, isn't great. And, here you have somebody who's progressed pretty rapidly on, platinum-based doublet as well, etoposide and carboplatin. So, and then, but the peculiar thing here is that, this is oligoprogression. He's not progressed anywhere else, which is pretty surprising for somebody with small cell neuroendocrine transformation, because they usually present with florid mets, pretty widespread distant metastatic disease as well. But that hasn't happened here. So, which is why it's actually pretty interesting. But I mean, like, just out of curiosity, what was the key 67, Naren?
80%, sir.
Oh, it was that high. Okay. Okay. So I think, in that case, just wait, probably look at rechallenging with the platinum later with Kabazi. I mean, my choice would probably be Kabazi with carbo. If he's fit. I hope he's fit. Your patient is fit, right?
Yes, yes.
Yeah. So then I think I'll probably look at doing that. Not now, but at progression.
And so Arun sir was pointing out that PDL1 and PD1. Interestingly, we have Chinese data where all the toripalimab and serplulimab has worked extensively well in all small cell carcinoma, unlike the nivolumab and pembro. Still, it works like
Correct.
so.
Correct. I think
Fair
that's
point.
definitely there, but but the point is we don't have a head-on-head yet. Like I said,
Yeah.
the Astride study is interesting. I mean, like Atizo head-on-head versus Serpluli, we'll know. We'll probably be able to pick a winner there.
Okay. Okay, sir. Thank you. Thank you all.
So next presentation. Do we have any cases?
Yeah. Yes, sir. I am Dr. Prasanna from medical oncology resident from Chennai, sir.
Yeah.
Okay. Actually, I am presenting the case of a carcinoma. Actually, we have not done any NGS, sir, NGS testing. I am just presenting for the further evaluation and management plan. Coming to the history, 52-year-old postmenopausal woman diagnosed as a case of a left carcinoma of the left breast, clinically CT3N1M0 head-to-end invasive ductal carcinoma. Initially, patient received 4 cycles of TCHP regimen, then clinically partial response. Then patient was taken up for left MRM. Pathological staging is YPT1B N1A. Then adjuvant we continued with two more cycles of TCHP. Then patient completed 1 year of adjuvant trastuzumab. Uh, 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 During this time, adjuvant TDM1 was not given. Next slide. Actually, patient was kept under follow-up 3 monthly PET-CT. After 1 year, 3 months of disease-free interval, patient developed a metastatic recurrence. Next slide, please. In March 2025, patient developed a multiple metastatic recurrence, especially in bilateral lung nodules and right lung lower lobe 5 cross 4 centimeter lung lesion, and both lobes of liver, mediastal lymph node, and skeletal lesion. And also there is nodular lesion in suprasellar area and bulky pituitary gland. Then in MRI there is enhancing lesion in a cellular mass involving hypothalamus and also having contact with the optic chiasma. The impression favored towards the metastasis over the pituitary adenoma. So at that time, biopsy was not taken from any metastatic lesion. Patient was started on TDM1 first line therapy. After 1 cycle of TDM1, patient was not tolerated. She developed a severe oral mucositis and odinophagia. So again, MRI was taken. In that there was a new lesion in the right cerebellar hemisphere also. So there were two lesions. One is a cellular lesion and a right cerebellar hemisphere lesion. After tumor board discussion, patient received a SRS 5 fractions and a 25 gray to the cellular and cerebellar lesion. After that, because the patient didn't tolerate for TDM1, we started with the TDXT. Patient received 6 cycles of TDXT, 300 milligram. After that response PET-CT, there was a complete metabolic response of all lesions, even in a brain lesion also. So this is imaging of left side pre-TDXT and the right side post-TDXT imaging. So after favorable response, we continued with the further 4 cycles of TDXT, 200 mg. So after 10 cycles of TDXT, immediately after the next day of the TDXT, patient developed 2 episodes of seizures. Actually, we suspected because of hyperglycemia induced. So that time sugar was very high. So we treated with the anti-epileptics and also blood sugar control. That day MRI was taken. There was a new multiple small nodular lesions in cerebellum and brainstem, cerebral hemisphere and thalamus. But still we continued with the further 2 cycles of TDXT. Now Now patient totally completed 12 cycles of TDXT. Actually, now we have planned for a response assessment with the PET-CT and also MRI. And also we are planning to do liquid biopsy to rule out any resistant mutations. So for my questions for a panel discussion is, suppose if we take PET-CT, if any no any there are no, there is no extracranial disease, only CNS progression is there. Can we continue with the TDXT with the whole brain RT, or can we switch over to the next line option like tucatinib based regimen? Yeah, how much useful will be doing liquid biopsy in this case scenario? These are my questions.
So, Naren, you want to start or shall I go?
No, you can proceed, sir.
Okay. So, any particular reason as to why you brought down the dose of TDXT from 300 to 200? Because I didn't understand that. You said you
Yes, sir. Initially, first 6 cycle 300 mg, sir. Then some financial constraints reduced to dose 200 mg.
Okay.
Yes, sir.
And that is when the patient progressed. When the patient was on 200 milligrams, that's when she progressed. Is that right?
Yes, sir. Maybe reason, sir. It could be a reason.
Well, I don't know. I'm trying to ask, because I don't know. I'm just trying to ask.
Yes, sir. After 200 mg changed only MRI in brain, there were new lesions, CNS lesions.
And there was no other extracranial disease at that point in time. It was only oligoprogression.
Yeah, yes,
only
sir.
in the brain. And you've already radiated her, meaning given SRS.
Initially, first brain lesion we radiated, sir. Then after TDXT 6 cycles, then another next multiple small new lesions, sir.
Okay. But was it asymptomatic brain mets or asymptomatic brain mets?
Only two episodes, symptomatic, sir. Only 2 episodes of seizures. Other than that, patient was stable, sir. No other symptoms.
Okay, because I think with any symptomatic brain mets, we would all, and especially when the patient is already on a HER2, ADC like TDXT, I would have probably given a whole brain RT at that point in time itself. That's one thing. And then you could look at continuing on TDXT, absolutely fine with that. That's fine. And your other question about you've done a current image right now. Have you done a response assessment now?
No, sir. After 12 cycle, we are going to do, sir. Not done, sir, till now.
I think, and have you increased the dose back to 300 milligrams now, or is it still at 200 milligrams?
Still 200 only, sir.
Oh, okay. So I think, if you've done a response assessment now, and if, the lesions in the brain have also regressed, then fine.
Okay.
Go ahead and continue. But if it has not regressed, I think, just like how we have the HER2 climb O2 data looking at combining TDM1 plus tucatinib, there is data to do that. But unfortunately not yet approved, but nevertheless it's shown improvement in PFS 9 versus 7 months. So, I'd be tempted to add tucatinib, provided your patient is able to tolerate. First option, if no financial constraints, please go back to 300 milligrams. If the patient cannot afford 300 milligrams, then you have the options of going on to generic tucatinib. But I would add that to TDXT. I know that, it's not approved. There's no randomized evidence as well. It's not level 1 data yet. But I would look at doing that in this sort of a scenario. If the patient has got asymptomatic brain mets and which is stable, or it's not progressing. But if it is progressing or symptomatic, please go ahead and give whole brain radiation. And if that's oligoprogression, go ahead and radiate the brain, give whole brain RT, and then look at continuing on TDXT. But if you're coming down on the dose of TDXT because of financial reasons or financial toxicity, then I would suggest that you add at least tucatinib to the TDXT.
So, is there any option for adding pertuzumab with TDXT, sir? Will it be useful, sir? Any experience?
The problem, you're talking about the DB09 data, which led to the approval of TDXT plus
Yes, sir. First line, yes, sir. Yes.
The first line. But unfortunately, that's not exclusively only for brain metastasis alone. Yeah, so they did not exclude patients with brain metastasis. Here you have somebody who's progressing on TDXT, and how much will the addition of pertuzumab alone make a difference? Not much. So my take is, if you want to add another drug to TDXT, I would much rather add tucatinib rather than add pertuzumab, because I don't see that making much of a difference. And there is a data called Patricia study as well, phase 2 data, again looking at high dose trastuzumab plus weekly trastuzumab and pertuzumab as well in patients who have brain metastasis, but again phase 2 data only. And so I wouldn't really be pushing for pertuzumab for CNS penetration. I would much rather go with a HER2 selective TKI where I know the CNS penetration will be much better, and I would look at combining that with TDXT. And if for financial constraints that your patient is not unable to afford the full dose of TDXT, this is what I would do. I would suggest.
Is there any role doing a liquid biopsy, sir, to detect any resistant HER2 resistant mutation? Will it be useful, sir, in this case scenario?
Yeah, I mean, like probably if you have to repeat to check for the HER2 status, that's fine, but not for looking at the HER2 mutations. Because even if you happen to pick up a PIK3, PI3K mutations, like the ABO9, around 30% had PIK3 mutations, and the rest, I mean, like it was prognostically important, but the magnitude of benefit was still the same with TDXT in patients who had PIK3 as well, PI3K mutations. So advice therapeutically, it may not alter your decision making much. If it is still HER2 positive disease, HER2 driven disease, and looks like it because that's how it's behaving as well with isolated CNS progression. Because we know that those patients are more prone to develop brain mets. So probably the others can chip in as well. I mean, like Naren or Arun sir and
This patient is initially SRS done or whole brain RT done before starting TDXT?
SRS, sir. Yes.
Okay. Somehow this HER2 positive patient, whoever had SRS, I also had 2 or 3 patients. SRS not helping much. They somehow progress fast. So my suggestion is you ask for liquid biopsy. Liquid biopsy will not have any shedding from the brain into the blood, so it will not be useful. And anyway, it won't give any additional benefit here, even if it is resistant mutation is there. And the second point, as sir said, you can go ahead because patient is symptomatic. You can go ahead with RT, and then I would consider of adding tucatinib. We know that there's no data approved data. The trial is going on for adding tucatinib with TDXT, but still I would add tucatinib and continue TDXT. Or if patient cannot afford, at least TDM1 with tucatinib I will consider. TDM1, you said the patient had a reaction, probably a lower dose. You can start at a lower dose with the tucatinib. Those are 2 options I would consider.
Yeah. So I think ideally, if your patient can go back on the full dose of TDXT or the actual dose 5.4 mg per kg, which was 300 milligrams that you began with, ideally that's the best option. If because of financial toxicity your patient can't do that, then and also if the cranial disease is also well under control, then you can add tucatinib. No harm in doing that for financial constraints. And if symptomatic brain mets, then radiation, whole brain RT.
Okay, sir. Okay, thank you, sir.
Right. So we have last case for today's discussion. So Dr. Vidya, please proceed.
Yes, sir. Can you hear me, sir?
Yes.
Good evening, all. Next slide, please. She's a 55-year-old female, postmenopausal with no comorbid conditions, diagnosed with carcinoma left breast, triple negative, T4B, N2, M1 with multiple lung secondaries, with K67 of 12%. She underwent 6 cycles of Pacli carbo because I added carbo because of the germline BRCA BRCA with the VUS. After 6 cycles, PET-CT almost near complete response, both in the primary and the lung nodules. Next slide, please. My question is, can we take this VUS as a germline? Whether we can add olaparib as a maintenance and also for genetic counseling. Next slide, please. We can see the NGS report.
Is there any family history of breast cancer or ovarian cancer?
No family history. No family history. No.
Okay. Thank you.
Arun sir or Sambhu?
Sorry, I'm here.
Oh, yes.
Yes, sir. So this seems to be a germline variant only because the variant allele fraction is 44%, but this was done on the block, is it?
No, germline.
Yeah, so it is definitely a germline. So that means they would have done this test from the DNA from WBCs, right?
Yes,
So
sir.
then it is definitely a germline variant. But this again, for academic purpose, I'm saying variant allele frequency giving in a germline report suddenly has become a new thing in most of the labs. I don't know why. Because if it's germline, you don't need to know the variant allele. What is important is zygosity, heterozygous or homozygous. So that way, anyway, that apart, this is germline, but I would not act upon it. I saw the ClinVar for this variant. It is definitely a VUS. Although this is a deleterious variant. You see, this is causing a deletion from the 1928 amino acid, which is towards the end of the BRCA2 protein. So I would strongly suggest doing a genetic counseling for this patient and
Okay,
see
sir.
if cascade testing can really help. So that would be my takeaway. I would definitely suggest a genetic counseling.
Okay,
Yeah,
sir.
same. I will go with that. So currently you can do the genetic counseling. So, but we cannot take any treatment decisions now at this moment.
I think, yeah. So I think, like everybody was rightly pointing out, yeah. So I think there are no therapeutic implications based on a VUS or a variant of unknown significance. But given that it's a deleterious variant, you could look at offering genetic counseling and then cascade testing. You said probably there's no family history as well. So,
Yes, sir.
so
There can be, because it's a metastatic disease, already 6 cycles completed. I have almost near complete response. So I have to give some maintenance. I cannot leave it alone. So whether I can give olaparib as a maintenance now?
unfortunately, the data says otherwise because, the current approval is only for pathogenic or likely pathogenic variants. It's not for VUS. So if you look at it from from a data point of view, PARP inhibitors definitely are not an option here. I know your patient has responded well to platinum. You've added a platinum, had a very good
Yes.
response. Probably if you want to, contemplate giving a few more cycles of that also. If your patient has tolerated it well, that's also an acceptable strategy. But PARP inhibitors here probably, there's no data. We can't act on it. Like I said, it's got no therapeutic potential.
Okay. Okay. Thank you, sir.
Sure.
Sir, what about pembrolizumab here? So
So
maintenance.
PDL1 is 4% only. So if it's more than 10% only, we can give.
Okay.
Correct. But then again, if you look at the NCCN is already advocating for ADCs in the first line, either saxatumab or datopotamab, even before the FDA approval. So I think that's again a word of caution for everyone, whenever we look at the NCCN guidelines, always remember that, they can endorse whatever they want to, whether it's approved or not, because they are an independent body based out of the US and that works for the American patients. So I think just a word of caution there, because we know those ADCs are not yet approved, even in patients who are not eligible for your IO or less than 1% as well. But they've already suggested that that becomes an option as far as the NCCN is concerned. Moving forward, that could very well get approved. That's a different question altogether. Even Saxi plus Pembro, SG plus Pembro as well. Or again, even in patients who cannot go on IO, then it could just be either Saxi or Deto. But as of right now, it's not yet approved.
So if this would have been ovary, you would have checked the HRD and then you have decided. But will it be, since there is a near complete response, will it tempt for you to do HRD here and then decide? I know it is not a standard.
No, correct. See, I think, it's always tempting for us to do a lot of things, but then problem is the HRD probably has not been standardized for breast cancer. I mean, we don't know. See, I think even there we talk about standardization between labs, and we've had that discussion on many a time. GIS versus GSS versus GAS. Each labs has their slightly different cutoffs based on the different loci of the allele. I mean, we've had that discussion, Naren. So I think it should definitely be standardized before we even offer it to our patients, because we need to know how it does. Or the standardization in breast cancer is different from ovarian cancer. So
Okay. Thank you.
Yeah, I think here we can conclude today's discussions. So I thank all the attendees, panelists, as well as the experts who have joined today. So there is a feedback form that's being circulated in the Zoom chat box as well as in the WhatsApp group. So I kindly request to all of you to fill it and send to us. So we can adjourn today, and we'll meet in the next VMTV. Thank you all.